Well, hello there. Oh my goodness. It is so great to be back this week. I have to tell you that summer is off to a pretty darn good start. Now, we are preparing to go on our long awaited trip. So, we are actually heading to Japan. We're really excited. This is something we've been dreaming about for a really long time. And I realized that we adopted chicks this spring, which put me behind a little bit in my podcast recording. Okay. However, we are back stronger than ever, and it is going to be an amazing next several episodes. So you're definitely going to want to stick around. I mean, we have some really, really great topics coming up. And when I say we, I mean I do. Okay. So today's topic is really remarkable, and it is one that is becoming more and more common. So I think it's really important that we talk about it. Okay. So we're actually going to be talking about what do we do when we have a leaner woman? Okay. And I say leaner, meaning hasn't struggled with her weight really ever in her life. And now she's gaining weight in perimenopause and menopause. How do we manage these patients? Okay, so we're going to dive in today. But before we do, I just want to remind you that I have an awesome nutrition training program. It is 48 CME credits. It actually gets you a whole year of access. There's 24 modules that are extremely informative. There are many, many Q&A replays, and then we meet once monthly where you can ask me all of your questions. It's an awesome group. I'm really proud of it, and it's really cool because, I teach some of the things that we don't always see in clinical practice. So I really emphasize in body, how to evaluate muscle mass percentages, things like that. So I'm really excited to offer this. You can check it out, www.thefitcollective.com/nutrition hyphen training. All right, my friends. So let's get to it today. So I have to tell you that we are blessed in my coaching program for women doctors. Dr. Komal Patil Sisodia, she's an endocrinologist, obesity medicine doctor, and she's a menopause expert. So she actually came into the group. She's actually been with me for a really long time, but came as a coach in the group about a year ago. And she actually supports all of the women with perimenopause and menopause. So she's not the prescribing doctor for them, just as though, I'm not the prescribing doctor for a GLP-1 agonist necessarily, but absolutely can direct them in the right way. So I'm kind of starting off to say that earlier this year, I said, hey, Komal, what hormones am I getting checked? What are my labs? What labs do I get checked? And so she gave me the whole panel to go and get checked. I was just noticing I was definitely sweating more at night. I was for sure fatigued midday. So it's hard to say what is this, but I did notice that my once really abundant energy was definitely lacking. And so she gave me the whole panel. I went out and got my day 3 hormones. I mean, we all know hormones fluctuate and whatnot. And I have to tell you, pretty darn eye-opening. And I don't hold anything back here, so I'm just going to be completely upfront and honest. When I was 30 years old, I can remember getting my testosterone checked, and I know it was 55. It was a good old whopping 4. Okay, so it was 4. The other, hormones were starting to tank as well. And, it was interesting because, living in the Philadelphia area, we have access to a lot of amazing specialists. And I actually had a meeting, actually an appointment, meeting appointment with a menopause expert here. And she was able to guide me really kind of the next steps in the management. So I bring this up because, okay, I wasn't having massive symptoms of perimenopause. Okay. I was having symptoms though. And one of the things that happens is that a lot of us, when we seek kind of care or help for perimenopause and menopause, we're deep into it. Okay. So I want to put that out there because these are often the patients that are coming to us. All right. So, the other thing I want to put out there is if somebody has never struggled with their weight and they come in to see you, okay, we have to remember that stigma goes both ways, right? So, it's easy to judge somebody and say, oh, you're overweight. This is why I think you're overweight. Well, also too, you're thin. You've never struggled before. Why should we kind of take what you're saying seriously? And we really have to take all cases serious. And I'm going to explain a little bit more about that. And actually, today's episode is going to be completely focused on, what are the first steps? What do we do with somebody who has not struggled with weight before? Now they're in perimenopause, menopause. They're doing everything right. They come in. What do you do? Right? Because your first step isn't going to be like, okay, well, you don't meet any of the criteria for medication. I'm going to give you medication. Right. But, and they may be on the way to developing, okay, comorbidities that potentially would put them at risk, that potentially would then set them up for needing medication or even qualifying for medication based on the standards that the insurance companies use. Okay, so this is such an important topic, but next week's episode, okay, you're going to want to stick around because next week's episode is going to basically be on the paradox of the BMI. Okay, I'm excited about that one because in that one, we talk all about the idea that somebody with a high BMI could be actually very lean and have no metabolic disease. And then you can have somebody with a normal BMI and they might have, metabolically, maybe in a metabolically diseased state. Okay. And again, that can be more of a normal weight metabolic obesity. So we're going to talk all about that. But let's get back to our problem at hand. So have your perimenopause. Let's call her something. Let's give her a name, Laura. Laura comes in. Okay. Laura is 45 years old. Laura has been an athlete most of her life. However, hasn't been as active in the past 10 years. She has 3 kids. She's really, really busy. Not really strength training, but she walks occasionally after dinner, things like that. Does not overeat. In fact, she says she's doing everything right. She eats plenty of protein. She balances her plate. She actually doesn't drink alcohol. And the other thing about Laura is that she sleeps pretty well at this point. She's not really mentioning a lot of perimenopausal symptoms. However, there is a checklist, by the way, and if you're women who are about, anywhere from, I don't know, 35, like Como always says, it can start at 35, but giving out the checklist, there's a menopause checklist, symptom checklist. You'll be shocked. I took the checklist. I didn't think I was having that many symptoms. I had all of the symptoms. Okay. So I digress, but I'm coming back now. So Laura is concerned because she's not really doing anything different than she has over the past 10 years. She's busier than ever, sleeping okay, all those things. And all of a sudden, she's starting to notice some weight gain, particularly around her middle. None of her clothes fit. She doesn't feel good about herself. She notices that she's always kind of holding her hands over her stomach. She's avoiding photos. She has not put a bathing suit on in a long time. And, her BMI is hanging out at about 24.5. Okay. So she has noticed, about a 10-pound weight gain and she's really concerned. Okay. So what are you going to do with Laura? All right. What are we going to do with her? Because we want to be there for Laura, right? Now, Laura will tell you that she had her labs checked because you're acting as the specialist. Laura had her labs checked with her primary care doctor, and they're fine. They're actually really, really good. Her hemoglobin A1C is 5.2. Her cholesterol, her LDL is still in the normal range. However, it has bumped a little bit in the past couple of years since she last had it checked. But overall, everything else looks pretty good. Okay. She doesn't know the exact amount of inches that she's increased in her waist, but her clothing size used to be about an 8 and now she's about a 12. So she definitely has had some increased circumference in her waist area. She's never done an in-body scan. She doesn't know what one is actually. She's only ever relied on the scale. Okay, so I'm going to walk you through how I approach this, okay, because my practice of obesity medicine is a little bit different. Okay, so this is a very common client who is coming to me. This is my bread and butter, baby. Okay, and that is why Dr. Patil Sasodia is in my group because this is my bread and butter. Okay, and so I need to have perimenopause and menopause support in my groups. Okay, so what we have to realize is that, as providers, like potentially we could have thoughts on these things and really important to kind of just hold space because this is all about your patient. I'm going to say client too, because if you're working more in a capacity where you're not prescribing and maybe you're working in a coaching space, okay, then we'll call it client. But for purpose of today, we'll just say patient. The idea is that we have to find out a little bit more where their head's at. Step number one is really going to be that motivational interviewing. Okay, that is so important. We cannot bypass it. Okay, so motivational interviewing, I talk a lot about this. Actually, this is my longest module in my nutrition training program. My husband is a psychiatrist, and so I really kind of tapped his expertise. He was actually in that video with me, and we talk all about motivational interviewing. But really what we have to do is we have to get to kind of the thoughts that she's having. Now, super important, right? Because in order for you to have a successful motivational interviewing session, you have to gain trust. Okay. And so the thing that I'm going to recommend to you is that you acknowledge the unique physiology that's happening during perimenopause and or menopause, right? Because it can be, I tend to see women more in perimenopause. I have some clients that had come to me already in menopause, but most of mine are coming in perimenopause. So just acknowledging and affirming, yes, you are undergoing unique physiology. Okay. So here's what's happening. Saying things like estrogen is decreasing. Okay. That's just right there. Okay. So I have to tell you, and I'm going to speak very personal. My anxiety became worse than ever over the past 3 years to the point where I really had to ask for an SSRI. My anxiety was so bad. And I've always had a little bit of anxiety, but it was to the point where I was ruminating all the time. Okay, so this is before I really got into kind of the symptoms of perimenopause. Okay, so I started the SSRI, definitely took the edge off, but I didn't feel that I returned back to my baseline necessarily. Okay, so we know that estrogen is really, really important with how we think. So when estrogen is declining, remember, gaining 5 pounds 10 years ago, we probably would have said, oh, that's no big deal. Let me see what I'm doing and let me tweak a couple of things. Not a problem. But when we have more heightened, let's just say, anxiety, and I'm not saying this is going to happen to everyone, but it's really common, then all of a sudden, kind of that weight gain becomes even more concerning. So just keep that in mind. Okay. So cortisol increases. Now, genetically speaking, some of us are more predetermined to have a more heightened cortisol response. Okay. And that's genetic. So it's actually our cortisol receptor hormone. So I actually test for that in my genetics program. So I use a genetics cheek swab. And one of the things we do look for is the cortisol gene. And sometimes with a variant, about 30% of the population is going to have increased cortisol with a typical stressor. So in perimenopause, menopause, that can be even more increased. So we have increased cortisol. And we know that when we have increased cortisol, it's going to prevent insulin from working appropriately. Okay, so it's actually going to prevent insulin from really driving glycogen and whatnot into our muscle cells, our liver cells. And so there's a lot more glucose hanging out in our bloodstream when there's more cortisol present. So then what happens? Well, then we produce more insulin. And over time, this can lead to insulin resistance. Okay, so even if you have someone in perimenopause or menopause that has completely normal labs, this doesn't mean that they are not somewhat insulin resistant. This is what starts to happen, when we're in perimenopause and menopause. Okay, how about testosterone? Yeah, that tanks. I can tell you for sure that tanks, right? That was the biggest number I had really tank. And, as women, and actually there's a lot of amazing women in the hormone space. Dr. Kelly Casperson talks about it all the time. But, testosterone, you have to get it off label if you want to, basically do something that's going to be dosed appropriately. Okay. So, in general, you have to really kind of work if you want to replace this. And then obviously, replacement of hormones isn't going to be for everyone. Right. And so there's that whole nuance. But testosterone goes down. So what happens when testosterone goes down? Our body composition changes. We don't hold on to muscle the way that we used to. We don't gain muscle the way that we used to. So we actually have a risk of having a higher body fat percentage just because the testosterone goes down. Okay, our thyroid function, okay, in this time period can also go down. So our thyroid isn't working as great. Loss of muscle by the age of 30, right? right? We're losing about 1% of skeletal muscle mass per year if you're not optimizing your nutrition and if you're not optimizing your strength training. Okay, this is a huge deal. Sarcopenia can develop. So then what happens? Well, now your basal metabolic rate is even lower, and your testosterone is lower, and your estrogen is lower, and your cortisol is higher. So we are not painting a great picture here. Of course, weight gain is going to happen. Of course it is. Okay, so again, I'm telling you all of these things and I'm taking my time here because even if you remember one thing to tell your patient in perimenopause or menopause, this is what you want to tell them. You want to tell them that they're not making this up. Okay, this is real. Okay. Um, and then remember this, right? I talked to you a little bit about my own anxiety. So in this phase, our serotonin and our dopamine is also decreased. Okay, so think about it this way. What do we do when we need a dopamine hit? All right, I'm going to hit the pantry and get some chocolate. I'm going to grab myself a cocktail. Okay, we're typically going to do things that will make us feel good and feel good fast. And that's why the behavioral component of, all of this work as it relates to obesity medicine is really, really important. And then finally, like sleep, let's talk about that, right? So in perimenopause and menopause, sleep, even if you think you're sleeping well, it might not be as restful. And this is where you hear women report that they're waking up and they still feel exhausted. They feel as though they never went to bed and they didn't sleep. Okay, so again, we know that this is common. So, what happens when your sleep is not as great and you're not getting that restful sleep, or you're waking up at 3 a.m. and you can't get back to sleep? Okay, well, stress is going to go up. All right, so potentially we're going to have more increase in our cortisol. Insulin sensitivity is going to go down. So I'm not saying you're insulin resistant yet, but there's a lot of studies out there showing that less than 7 hours a night is actually going to increase your insulin resistance. So it decreases insulin sensitivity, increases insulin resistance. Okay. And then guess what happens? When you have disturbed sleep, your hunger hormones get all messed up. Now your ghrelin is higher. Your ghrelin makes you hungrier. Okay. So even if you think you're not eating more, you might be. Okay. It's so, like, I just named so many different scenarios. The physiology is incredible during this time period. Okay. So I have to tell you right now, if that was your visit and you just went through all of that and affirmed that this is a challenging, complex, nuanced time frame in a woman's life, you're already successful. You've already given them a gift. They just need to be heard. They need to be, told that you're not making this up. Like, listen, we got you. Okay. So perfect. So that's a great way to kind of enter into motivational interviewing. Okay. And so this is really important because what I have to tell you is, they're coming in there not necessarily looking for medication. In fact, like so many of them are resistant and don't want medication, even if they already would qualify for it. I mean, I have to tell you, medication often, we don't get to talking about that till a year in, okay? And this is for individuals who maybe would have qualified, that year previous. And so really kind of asking, what are your expectations? What do you want to achieve? What are you willing to do? What are you currently doing? Okay. So all of those questions. And again, I go over this in pretty extensive detail in the training program. So if this is something of interest to you, definitely check out the nutrition training program. But in general, like I said, it's just bottom line, getting to know where your patient is at. Okay. The next question, this is really important. So you have the motivational interviewing, number one. Number two, you want to take a weight history in their adult life. Okay. Because if you have somebody coming to you, right, and they've gained 10 pounds and they say to you, I want to lose 30, and then you ask them their lightest adult weight, and it was not 30 pounds lighter than they are, that's not realistic. Let me just say, and again, make this really clear for your kind of leaner individual. Now, right? You might have somebody who is not in the leaner I'm using leaner in reference to they come in and their BMI is not going to be traditionally, I don't love the BMI, but let's just say they come in, you look at their chart and their BMI is under 25. Okay. So if you have somebody, in the 27, 28, 29 range and whatnot, you might already be thinking about medication. Okay. But traditionally speaking, and I don't agree that you're going with BMI to prescribe medication. That's not how I look at it. And you're going to hear more about that in next week's episode. But for right now, it's this idea of what is their weight history? Okay, so if they tell you that they've been the same weight pretty much their whole life, and then, the last couple years they gained that 10 pounds, okay, you're able to stay more focused. If they tell you that their lightest adult weight was 50 pounds ago, okay, then again, different story. Because if they again were 50 pounds lighter at one point, then they've gained 50 pounds over the past however many years, and you're dealing with a different metabolic state. Okay, but I'm assuming that if they are, on the leaner end, we're going to call it, that most likely they're going to say that they've been about the same weight, and it's been over the past couple of years that they've noticed about a 10-pound weight gain. Okay, that's going to be kind of the typical story. It may be a little bit more than that, but in general, that's what you'll hear. Okay, really important to get an assessment on that. And I think it's also really important to say, hey, listen, at this phase in the game, if you are not taking weight loss medications, you can't expect to be lighter than you ever were in your adult life. That's the reality. Okay. So if somebody wants to be a lot lighter than they ever were in their entire adult life, that's going to probably require medication. And that's typically what we see. Okay. I'm trying to give you as much information as possible because these cases are nuanced and they're not all the same. So I'm just giving you a lot of things to work with so that you can use them in your interviews and in your patient visits. And I don't know ultimately what you'll decide, but I want to give you kind of all this space for you to be able to decide with your patient what the best next step is. And that's the other thing to remember. Your goal isn't to you take responsibility for their weight loss. We do that all the time. We put it on us as their provider, right? We want to own that we are responsible for their result. Okay. But we're not. We are responsible for being on the journey with them and supporting them and ultimately coming up with the plan that we both agree on, but it's a team effort. Okay. All right. So that's two. Number two is taking that weight history. Number three, gosh, gotta get a body composition. You've got to. And if a patient is resistant to this, I will tell you this right now. You are going to have a lot of trouble advising them in a way that's going to be beneficial immediately. Okay. If they do not want to get an in-body and if they're resistant to it, now I have to tell you, I have not seen anybody resistant to an in-body yet. And this is why. In-bodies are way more empowering. In fact, my older daughter, who is 13 and she's almost 5'9", she only gets on an in-body because we look at her muscle mass. We don't care about her numbers much, right? And she has an amazing body image. And I'm telling you, in-body scans for many individuals, I found, and I continue to stress this, it changes their relationship with their body because they can look at the in-body and say, "Oh my gosh, I have I have this much amount of muscle mass? Wow." The first thing we say with our clients when we see our in-bodies is we go right to that muscle mass and we're basically saying like, "That's awesome. That is awesome." And again, in my training programs, and we actually do this in my Transform program, we talk about, what their optimal muscle mass is and, are they currently optimal? A lot of people are surprised that they currently are optimal. So I bet if we took our lean individual who's in perimenopause and we put them on an in-body, you're probably going to get one or two scenarios, okay? Scenario number one is that they have enough muscle mass. And again, usually how I predict this is if they're under 200 pounds, I want to see about 60 pounds of muscle. Many are not going to have 60 pounds. But if you take their skeletal muscle and you divide it by their total weight, if they're under 200 pounds, I want to see 30% or more That's going to be adequate muscle mass. All right. And the other scenario is if they're over 200 pounds, I want to see at least 60 pounds. Okay. Now, once we start getting higher up into the 200s, 250, I want to see 70 pounds. So I have an algorithm that I use. Okay. But that's the first thing I'm looking at. So the one scenario is that they're going to have enough muscle mass. Okay. The second scenario is going to be your naturally thin woman. Okay. Who couldn't gain weight in childhood, was a very thin young adult. Okay. There I often see that their muscle mass is actually pretty low, all right? And this is going to be a much more difficult case to manage. So your naturally thin individuals, okay, who have been lighter than all their friends their whole life and now have noticed, and they still look very lean and closed, very thin and closed, but they tell you that their waist is about 5 inches bigger and they've gained 10 to 20 pounds. We'll just say 10 pounds we're using in today's episode. That's gonna be a more difficult case typically, and it's because their basal metabolic rate is usually lower, and so the calorie deficit that we have to put them in if they want to lose body fat, it's not usually pretty. It's kind of not my favorite. So a lot of times with that body type, we have to reverse diet them, okay, where we have to actually get their body to tolerate higher calories slowly over time and help them build a little bit of muscle before we can help them lose body fat. So it's actually a body recomposition we have to do, okay? And we actually have one woman right now that we're working with really in a very high touch manner, and she's reverse dieting right now. She's gaining muscle and now she's seeing her body fat percentage go down because she's gained muscle and now her body is actually releasing body fat. So she's a naturally thin individual who's now completely recomping her body, but that's a totally different strategy. So most women who are coming into you are going to be that first category. They probably have enough muscle mass. Okay. And so we're talking fat loss here. But in the face of all of these physiological changes that are happening in perimenopause and menopause. Okay. So we want to get the in-body scan. What you're doing with the in-body is you want to look at the muscle to body fat ratio. Okay. I always say the first goal is to get that body fat ratio less than their skeletal muscle mass. Okay. When we reach that goal, do you want to know why I picked that as a goal? Over the years, I mean, I've looked at thousands of in-bodies now. And again, this is the Ali Novitsky way. Okay, this is not. This is something I've observed. Okay, and so this is what I use. But essentially, what I find is if I don't have access to a visceral body fat measurement, okay, and typically we want it less than 10 for visceral body fat. If their total body fat in pounds is less than their skeletal muscle mass, I see that visceral body fat, when I look at a professional in-body or even a DEXA scan that has that information, their visceral body fat is within normal range. So I feel pretty confident when we can get to those numbers that metabolically speaking, we're in a good spot. Okay. And not everybody's going to have access to a professional in-body. Not everybody's going to have access to a DEXA scan. Okay. So I come from rural USA. My dad is a country doctor. His office is in our house. And so for his patients, he puts them on an at-home in-body because he doesn't have a professional in-body, and it's better than nothing. And so I just want to put it out there that there's so much knowledge in that in-body. You can actually look at an in-body and tell somebody their body type. I know based on a certain amount of muscle mass if they're more likely mesomorph or ectomorph. Ectomorph is the naturally thin, mesomorph is the naturally muscular. And then based on their body fat in pounds, I know if they're a meso-endo combination. So again, over time, when you're looking at these things again and again and again, you can see this and you can get that information, and then kind of knowing in general what happens, you can really advise and give your patients realistic expectations. Okay, so getting that in body or some kind of body composition, super useful. Okay, that's going to be kind of like non-negotiable. So if somebody says, I'm not getting one, right? in my department, right, if I don't have one, I can work with it, but we can't focus on percentages then. And it's very doable. Like, in fact, in my physician coaching program, we use intuitive eating. They don't have to have an in body. We use mindful macros. They don't have to have an in body. Okay. However, we review those scans, so they're welcome to have an in body. So, with that being said, if somebody's coming into you and they're giving you pounds, okay, that to me says that they probably will be willing to do a body composition. Okay. And if not, fine. You know what? You're going to go down the route of what are they willing to do? You go back to the motivational interviewing. Okay. So that's number 3. Number 4, this one comes with a lot of resistance: nutrition audit. Okay. So what this means is that you're having your patient track their food for 3 to 7 days. Okay. They're probably going to have to weigh and measure it. They can eyeball it. But if you really want to get an idea of what they're currently doing, you have to say this to them. This is not to tell you you're doing something wrong. This is to get the data on what you're currently doing so I can actually give you recommendations that will work. So you're going to have a lot of people coming into you and they're going to say, I work out, I eat right, I get all these steps. You're going to do their nutrition audit, and you're going to see that they're eating well beyond their calorie deficit. Okay. Maybe you're out there thinking, well, maybe they have leptin resistance. Okay. Which is a reality. So, leptin resistance, essentially what it does is, so leptin is made in your fat cells when you lose body fat. Okay. Your leptin gets lower. What happens with leptin resistance is that you have plenty of body fat, but your brain doesn't register that you do. So, your brain thinks you have low body fat. Okay. And so what happens is when you go into a calorie deficit and your body tries to release body fat, your brain says, no, we can't release body fat because we're starving already. We have to lower our basal metabolic rate. And so that's the problem with leptin resistance. Okay. So the reality is that, yes, you need a calorie deficit to lose body fat, but in the face of leptin resistance, it's very difficult to actually get to a deficit. And more, it's actually very, very difficult to maintain that deficit. And that's the reality of fat loss. You have to maintain a deficit over a longer period of time. Fat loss is not a quick process. If you're maintaining muscle and losing body fat, the most that we can even hope for, okay, for a long-term, strategic, reasonable approach is about 0.5 pounds of body fat lost per week on average. That means that some weeks you're not losing anything. And then some weeks you're going to lose zero point 0.5. And then some weeks you're going to lose 1.5. But on average, okay? So getting back to the nutrition audit, you have to say to them, this is not for us to check and see what you're doing wrong. This is so that we can help you. And here is really the most important thing. They cannot clean up their diet and then do the nutrition audit. No, because they're going to come to you with a perfect nutrition audit showing that they're hitting their deficit, and you're going to believe them, and you're going to, you should believe them, of course, but you're going to say, oh yeah, there might be something wrong with you. It looks like you're in a deficit already and you're gaining weight. And that's not the reality, because they weren't in a deficit until you told them to do the audit. So I always say to my clients, I say, listen, do not change what you're doing. This is a no judgment zone. Do not give me a pretty in-body, or do not give me a pretty nutrition audit. Be real with me. Okay. And then some people will say, well, what if somebody's really resistant to it? Okay. If they're not going to do the nutrition audit, then here's the deal. You're not going to necessarily be able to give them that to the point information to make the changes that are going to start working right now. So I see this all the time. I'm doing everything right, and they come in and they're eating 1,500 calories. So in their mind, 1,500 calories is not a whole lot. It's really not. And that's not their deficit, right? And we have to tell people that, and that's not your deficit. And that's what you're going to see. You're going to start seeing more of that in perimenopause and menopause. They're eating what used to be their deficit, and it's not their deficit anymore because there's all this other physiological stuff going on. Okay. Okay. So nutrition audit, again, once we do the nutrition audit, and this is in my nutrition training, I teach you not only how to do the nutrition audit, but I actually give you my whole guide to walk you from start to finish with your patient. And I teach you how to compare their basal metabolic rate to what they're currently eating, and then I show you what we do to help them lose body fat and maintain muscle. I show you what to do if they want to actually gain muscle, because as I mentioned, that might be a scenario you need to use in perimenopause. Okay. And that's not one we talk about a whole lot. I mean, we're starting to talk about it, but not all the time. Okay. So that's going to be really, really critical. And then the final piece is really just doing an exercise inventory. So what are they currently doing? Okay. So we said Laura is walking a lot. Okay. So she's probably getting, 7,000 to 10,000 steps. So I say, if you're getting 5,000 or under, you're sedentary. So we need to at least get you out of the sedentary range. Okay. But here's the next thing. Is Laura strength training? Laura is not strength training. Okay. So you say strength training to somebody, and if they're not doing it, they're going to say, I don't want to hurt myself. I've never done it before. I don't go to a gym. I will look silly at the gym if I do go to a gym. Right. There's a lot of excuses. I don't have the time. Okay. So what we've shown in our programs is 10 minutes of resistance training 3 days a week. Okay. Not only improves longevity, but it will at least allow you to maintain muscle while you lose body fat. So my individuals who are doing 10 minutes 3 days a week and hitting their adequate protein goal, they are not losing muscle mass, even on GLP-1 agonists. So we aren't seeing that because strength training is such an important component. It is so important that we actually made a 3-level beginner strength. So we have level 1 where they can sit in a chair and do the strength training, and it works. Okay. So I just want to put it out there. If somebody says, well, I can't do this and I can't do this movement, I can't do that movement, we've taken that into account. In fact, my beginner strength started because my mother-in-law went on a weight loss journey. She's lost about 100 pounds and she started to lose muscle mass. So I created this program for her. And she hasn't lost any more muscle mass, and she's lost about 100 pounds. So she's, well into her 70s, right? I just had an 80-year-old couple buy my beginner strength training program, and they're actually doing it together, okay, which is just, really special. So I want you to realize when somebody gives the obstacles, right? That those are real, like in their minds, like those are big obstacles. And so really a compassionate thing that we can do is say, hey, listen, I see you. Yes, those are obstacles. And what about 10 minutes, 3 days a week? Or can you start with 10 minutes, 1 day a week? Okay. All right. So again, kind of recap, right? The idea of strength training is really non-negotiable at this point, and there are programs and are ways that they can do it without it taking much time. Now remember, strength training is what's going to preserve your muscle mass. So if you think about exercise, so cardio is like your debit card. Okay, you do a session of cardio, you burn some calories. Strength training is an investment, a really good investment, because you are slowly maintaining muscle and or building muscle. Okay. So over time, you're actually preserving your basal metabolic rate. So you're going to have a higher calorie burn year after year after year. And I have to tell you, that's going to be enough potentially to prevent excess weight gain. So I saw there was an interesting little video the other day, and it was talking about, being a 30-year-old woman, it's really crucial that you're doing the strength training now, because then when you're 45 and you're going into your doctor's office because now you're gaining weight, right? At least, if you've preserved your muscle mass, it's going to be less. Okay. All right. So we got the motivational interviewing piece. Okay. We got taking the weight history. We have in-body scan. And again, I don't expect that you know how to evaluate the in-body scan right now, but knowing that that's a good thing to do. Okay. Nutrition audit. Okay. Again, I don't expect that you necessarily know how to do the audit, but having them track so at least you can say, okay, and this is the amount of energy you're eating on a daily basis. And then really doing that exercise inventory. Okay. So that's where I'd start. Now, depending on whether or not you're set up to help implement all those things, okay? If you are, great. If you're not, kind of giving them resources to be able to go ahead and do those things. Again, I highly recommend my beginner strength training. It's $197 for the whole year, 52 weeks, not one workout repeats. Okay, there's your strength training right there. Really kind of understanding simple protein goals. If your patient came in and you were able to give them a protein goal and tell them to limit their added sugar, they're going to see results, okay? While affirming that all of these physiological changes are actually happening. Okay. So, let's say that they do all of these lifestyle parameters, all of the things. So, they're ready to go. They do their in-body, they have adequate muscle, they do their nutrition audit. You kind of see where you can tweak some things. You increase their protein a little bit. You get them on a strength training regimen, okay? And they do all those things. And we are now, 6 months in, and they've been eating in a deficit and all of those things. And they go ahead and they get repeat labs. And pretty much is that everything is somewhat similar. Hemoglobin A1C is maybe 5.3 at this point. But other than that, Laura's kind of hanging in. This is what I want to say. In perimenopause, if the weight gain is already happening, okay, and they are doing all the lifestyle factors, particularly the calorie deficit for the nutrition, because nutrition is where the fat loss happens, to be honest. A lot of times people are going to want to over exercise, and that backfires, particularly with the hyper responsive cortisol. Okay, that's going to backfire. Um, but doing all the things in deficit and nothing is happening, okay, you know, if their waist circumference, so think of it this way, all right, for women, we want waist circumference less than 35 inches in a Caucasian woman, let's just say. And again, they're a little bit different. So, it's a little bit less for Asian. So just know that there are nuances amongst, so you just have to look them up because they do change. Like today, I was looking up body fat percentages for normal weight obesity. And it's interesting because potentially it would be lower in somebody who's Asian because their bones might be a little bit lighter. Might be. Listen, I'm not saying everyone is, but I'm reading the study today, and this is what they're saying that. So we have to just kind of take things all nuanced. But if waist circumference is 36 inches and labs are normal, there's some degree of insulin resistance there. Okay. So here's the question I want to end with. All right. I'm going to pose this question to you. Okay. It's not wrong to want to treat this. It's not wrong. Okay. We're almost pushing a 25 BMI. Now, insurance isn't necessarily covering this, right? But, hemoglobin A1C is coming up a little bit. In a deficit, 6 months, lifestyle parameters in check. Nothing's happening. This is not wrong to send them for further evaluation. Or if you're the one doing the evaluation, this is not unreasonable to start to think about, okay, is a medication indicated? Okay, so remember, there's good old metformin. Okay, there's other medications. It doesn't always have to be a GLP-1 agonist. But I want to put it out there that, and really the point of this podcast is that we are going to start to see more and more individuals who are not in the traditional overweight BMI or obese BMI range that will benefit from treatment. Okay. Because the alternative is if we keep watching it and watching it and watching it, and the lifestyle alone isn't enough, and we keep seeing numbers creep and waist circumferences creep and all those things, eventually we're going to get to the point where it's time to treat. So are we going to put them through all that and then treat? Or are we going to get ahead of the game? Because I believe that if we do get ahead of the game, then we're probably going to be able to get away with a lot lower dosing in the medication. And to be honest, right, it also, I think that, I think that you're going to have more people that are going to be more resistant to medication at this point. But I think it also really kind of helps open up the discussion on stigma with medications. All right, my friends, that was a lot. Maybe you'll go back and re-listen. But I want to encourage you to go ahead, stick around, catch me next week. Next week, I'm diving into the paradox of the BMI. This is a really good one. I love talking about this. So think about this through. Definitely go ahead, check out my website, thefitcollective.com. We have some awesome programs, nutrition training, 48 CME, my coaching program for women docs, Transform. We enroll in January, 72 CMEs. That's an awesome program. We have beginner strength. We have a total fitness program. We have a genetics cohort. So if you want to learn more about cortisol and hyper response to stress. If you have that variant, we have a couple of kits left for that cohort. So you can go ahead and check out the genetics programming. And I'm so happy to be here today with you all. And I'll see you next week. All right, my friends, until next time, we'll talk soon.